Good afternoon, everyone, and welcome to the 26th Annual Conference of the Uveitis Society of India. Today, I'm grateful to all members of the Uveitis Society and Dr. Narsingh Rao in particular for selecting me for this prestigious Dr. G. Venkataswamy Endowment Award. I'm privileged to join other awardees, Dr. Rao, Dr. Amod Gupta, Dr. Biswas, Dr. Ratnam, Dr. Rajiv, Dr. Sangwan, Dr. Vishali, Dr. Sudha, and Dr. G. N. Rao. The amount of teaching and publications these teachers have done and have contributed to the world of ophthalmology and uveitis in particular is phenomenal. My journey as a uveitis specialist, my talk will be on this. In the summer of 2001, I finished my post-graduation in Madurai. Dr. Nachar Madam said it was a curt one-line instruction. Doctor, we want you to start the uvea clinic in Aravind Eye Hospital, Coimbatore. Aravind, Coimbatore was 4 years old at that time and there was no uvea clinic there. I noted, yes, ma'am. For the next 3 months, I was in training in Dr. Ratnam's uveitis clinic in Madurai. Interestingly, it was at this point of time, Dr. Ratnam was seeing a lot of patients with leptospiral uveitis. In a typical day in our clinic, she would ask me to see a patient with anterior segment non-granulomatous reaction with vitritis, vasculitis, sometimes with a string of pearl appearance, and ask me what the diagnosis was. As I had seen a lot of patients at that point of time in our clinic, I would promptly recognize the entity and I would respond leptospiral uveitis. Invariably, the patient would also turn out to be leptomat positive. That was the beginning of her PhD journey and worldwide recognition. She still continues to publish on leptospiral uveitis till date. And this is a case scenario of what one can expect in leptospiral uveitis. The unilateral cataract in a young female, a pearly white cataract, an absorbing cataract, vitreous membranes and disc hyperemia in this image, vitreous membranes above and exudates below, and retinal vasculitis with vitreous membranes. I have been part of the Uveitis Society since 2001. I have attended every meeting since then till the pre-COVID days. In the first meeting, I presented a case of necrotizing scleritis with induced astigmatism, a case given by my mentor, Dr. Ratnam. I remember Dr. S.P. Garg from AIMS. He was the head of ophthalmology there at that point of time. I appreciate the case presentation. He was a constant present during those early days of uvea meetings. I was an awestruck youngster at that time, not in terms of age, I was 35, but in terms of uvea experience. Have rubbed shoulders with greats, Professor Rao, Professor Amod Gupta, Professor JB, Professor Carl Herbert, Dr. Kempen, Dr. Sangwan, Dr. Manfred, Dr. Chi, among others. Learned a lot from them. Started the uvea clinic in Aravind, Coimbatore in September 2001. It was a one-man clinic. I was really very skeptical. Am I capable with so little training to see patients? I learned along the way. I attended every society meeting, presented cases there, made presentations in ophthalmic association meetings, state, national conferences, etc., etc. In 2004, we encountered a series of patients who presented with yellow-white monofocal retinitis, mostly in zone 1. Three to four patients would walk into the clinic every day, all from in and around the city of Coimbatore. Clinically suspected as toxoplasmosis, proven with both ELISA, IgM, and IgG positivity. I remember Dr. JB was there at that point of time on a Sunday. He had come there for a CME. I showed him a few patients who had a review on Sunday that day for me. He saw the patients and confirmed cases were due to toxoplasmosis. So this was published in Archives of Ophthalmology, outbreak of acquired ocular toxoplasmosis involving 248 patients. Most patients were residents of one city in southern India. A total of 35 patients had a prodrome of fever. 242 patients had unilateral retinitis without associated old scars. All had lab evidence of acute acquired systemic infection with toxoplasmosis. All favorably responded to anti-toxoplasma therapy. Serology, toxoplasma IgM antibodies titers were strongly positive. IgG antibody titers were very high, suggesting a recently acquired systemic disease. The suspected source of infection was the municipal drinking water. So we concluded a large number of residents of any age in a population are at risk of acquiring ocular disease during an outbreak of toxoplasmosis, which can go unnoticed and can cause significant ocular morbidity. In the same journal edition that year, Dr. Holland had also published an editorial based on this, an epidemic of toxoplasmosis, lessons from Coimbatore, India, where he summarized other investigations have continued to follow up individuals infected in the Brazil epidemics. In each of those epidemics, new cases of ocular toxoplasmosis or recurrences of toxoplasmic retinoporoiditis have continued to be seen among individuals 1 to 2 years later after the outbreaks first occurred. And this Coimbatore epidemic emphasizes again the importance of toxoplasmosis as the public health problem and reminds us of the importance of disease prevention in the general population. We did alert the Coimbatore Municipal Corporation at that point of time. Maybe this outbreak is due to the source of the municipal water supply. This municipal water supply area is present in the outskirts of the city, in the foothills of the Nilgiri Hills. As part of my learning, I visited the US that year in 2004. Bascom Palmer and Mass Ian year I visited. It was here in Miami I observed Dr. Janet Davis giving intravitreal ganciclovir injection in the OPD for CMA retinitis. This was in the pre-oral valve ganciclovir era. There were a lot of patients to be treated with intravitreal ganciclovir injections. I went to their pharmacy where I observed how they make their 2 or 4 milligram doses of ganciclovir in Nepenthes, brought this practice home and started treating our patients here. Also spent 4 weeks with Dr. Stephen Foster in Boston. What impressed me most during this visit was his weekly interactions, meetings on Thursdays with fellows and residents who would be preparing for either an upcoming conference presentation, or they would be writing an article, or they would be doing a project. He would guide them and offer advice and supervise their project. As a medical consultant in the 10 years I spent in the UBA clinic in Coimbatore, we would see a daily OPD of about 30 to 40 patients. The total number of patients I've seen in Coimbatore, individual patients, is 5,400 plus. Had 3 cataract OT turns per week, did about 11,000 plus surgeries, cataract surgeries there. Academically was also busy as I was the DNB coordinator, and time was also spent for preparing for society, state and national conferences. Then came the next stage in my career. The next phase of my journey started when I was offered the Chief Medical Officer post at the newly started Aravind Eye Hospital in Salem, 2011. This put me in charge of a fledgling tertiary eye hospital with a team of less than a dozen doctors and a staff strength of 75 to start with. Continue doing cataract surgeries here. Till date, I have done 26,000 plus. I continue to look after the UBA clinic here, and my OPD strength is about, I've seen about 6,400 odd new patients here in Salem. Early days, I've done corneal repairs, trabs, etc. And of course, I had to spend considerable time in administration as well. It was in 2012 at the UBA meeting in Bhubaneswar, Dr. Rao wanted me to be elected as the Vice President of the Uveitis Society. 3 years later, I was automatically the President of the Society. In the 3 years I spent as the President, there were several firsts which I ought to highlight here. We organized the 15th Uveitis Society meeting in Aravind Eye Hospital in Pondicherry in October 2015. It was very successful financially also, as it contributed about 7 lakh rupees to the society. Here I had the advantage of conducting the meeting at the hospital facility in Pondicherry and could save on overhead expenses such as conference hall cost, board, etc. In 2016, we enabled the participation of the society for the first time in an international meeting, the 9th International Symposium Uveitis, sponsored by the IUSG group in Dublin. We had a session, the UVA Society had a 90-minute session titled Infectious Uveitis and Enigma. 5 of us presented cases there, Dr. Vishali, Dr. Salil Mehta, Dr. Nishant Kumar, and Dr. Ratnam, and I. My talk was on toxoplasma and rickettsiosis. My talk was divided into 2 sections there, and I presented a series of 12 patients with rickettsiosis, rickettsial retinitis, and that was published later as ocular manifestations of rickettsia conurae in South India. In our series of 12 patients, 23 eyes, retinitis was defined as the pale yellow lesion, obscuring blood vessel view, focal and confluent, seen in the posterior pole of the retina with or without uveitis, vitritis, and vasculitis. Diagnosis was based on Weil-Felix test, a positive Weil-Felix test, and or a positive ELISA, IgM and IgG antibodies for Orientia and Rickettsia gonorrhoeae. 8 patients underwent serology testing. Weil-Felix was positive in all the 8. And in all the 8, ELISA was negative for Orientia or scrub typhus. We got another kit which had antigen of Rickettsia gonorrhoeae, and that ELISA kit, which we tested in 8 of our patients, 4 were positive for Rickettsia gonorrhoeae, and that was our publication. All the patients responded well to standard therapy of doxycycline, oral doxycycline, and oral corticosteroids, and topical NSAIDs. The third, we created the Dr. G. Venkataswamy Endowment Award, lecture with a medal, with support of my senior leadership team at Aravind, to be given to eminent teachers who contributed to our learning and understanding of uveitis. And the first recipient of the award in 2015 was Dr. Narsingh Rao. I also started a template for a monthly newsletter, which I now believe is going very strong with plenty of contributions from a lot of uvea specialists. I would like to show you a sample of the newsletter, which was published in March 2018. This newsletter was to inform members about future meetings, national, international, or whatever. And it would also provide alerts for published uveitis articles, and ongoing studies from any member which has been published also would be reported here. Any member participating in any of the conferences also would be reported here. There was also a members corner where members can express their views and can have such case discussions, etc. So the upcoming and future events announced here. The USI meeting in Chandigarh in 2018 was announced here with article alerts, uveitis articles which appeared in peer-reviewed journals in the past 3 months, and images on recently concluded meetings were also published in those newsletters. So these were 4 accomplishments which I could do as the president of the Uveitis Society of India. I would like to add a case report, long-term ill effects of corticosteroids. These were personally experienced by me. As uveitis specialists, we all use a lot of oral corticosteroids for our patients as first line of therapy. But in the long term, what side effects can they cause? I learned that myself. It was in 1992 to 1994 where I had to take a lot of oral corticosteroids for a condition. In 1994, I was diagnosed to have avascular necrosis of both my hip joints. You can see the femoral head here with the loss of bone structure. I underwent core decompression with a fibula graft in both my hip joints. This lasted well for the next till 2021, where the right hip joint deteriorated and a total hip replacement was done at that point of time. In the meantime, from 1992 onward, changes had been going on my shoulder joints. You can see both the humerus heads with avascular necrosis and changes you can see there. And in July 2025, I underwent a hemiarthroplasty in a procedure called resurfacing. And this is how the joint looked prior to surgery. So we ought to keep this in mind when we prescribe our corticosteroid therapy to patients. They can leave our care, but still they may continue to experience various side effects of, especially side effects like this, long term. Now, coming to think of the future of the Uveitis Society of India, what would the USI be doing? We all should know or should be aware that 25 cases per 100,000 is the incidence of uveitis. Age-adjusted prevalence rates for endogenous uveitis is 317 per 100,000, and corresponding rates for all ocular inflammation is 467 per 100,000. So there is a considerable load of uveitis patients out there in the population waiting to be served, and primarily affects the working age group. 20 to 60 years of age usually get affected, mostly get affected. And our group of uveitis members, if you remember the newsletter, it was in 2018, it was 300 plus. Now it is 790. We have grown considerably in numbers in the past 2 decades, and our knowledge also has expanded. So what we should be doing is we should build capacity of ophthalmologists region-wise, conduct regional CMEs monthly, state-wise, and this was an award given to us when we conducted a CME, regional CME in Salem. And each one of us should make sure even the poorest patient is treated at par with those who can afford treatment. So I still asked myself, do I deserve this award? Do I have enough publications to, stand at par with the previous awardees? Then I asked myself, publications is the only metric by which I measure myself. No. I realized no. I'm much more than that, and only one of my identities is I am a uveitis consultant. So answering myself, I told myself I'm also a healer to thousands of my patients. I'm a passionate and ethical associate of my institution. I've been with my institution for about 30 years now. I'm also a leader, head of a teaching tertiary eye care hospital, and have led my institution for the past 14 years. People call me courageous, have fought many health-related battles. So we are one of the 8 tertiary care centers of Aravind Eye Hospital. And in a day in Aravind, we see about 700 to 800 patients at the base hospital, and about 200 patients in our vision centers. We have 9 vision centers, primary care centers, and we do about 120 surgeries, cataract and otherwise, in the hospital in a day. And in 2024 alone, we have done 40,000 cataracts plus specialty surgeries in Aravind Eye Hospital. Apart from that, outreach camps and classes happen on a daily basis. And this is my team. So based on all this, I told myself, yes, I accept this award. I should accept this award as a recognition of service done to my patients, to my institution, and to the Uveitis Society. I feel Dr. Venkataswamy himself has willed that this award be given to me. I do not know. Rao sir, did he appear in your dream? I would like to thank Dr. Rao in particular for considering me for this honor. Heartfelt thanks, sir. I thank the UVIT Society of India, in particular Dr. Ratnam and Sudarshan. They would never take no for an answer. They pushed me to accept this award, which I did. Thank you, madam. Thank you, Sudarshan. I would also like to thank Arvind Eye Care System and its leadership, especially Dr. D. Nachiyar and Dr. Ravindran, for constantly supporting me. I also take this moment to remember two legends of my lifetime, our founder chief, Dr. G. Venkataswamy, and our chairman emeritus, Dr. P. Swamy, who recently passed away. I would be failing if I did not thank or remember my father and mother. If not for their unwavering love and support, I would not have been here. Last, but in any way not the least, my wife, the rock in my family, who has stood by me in the past 33 years, helping me fight crisis after crisis. Thank you so much, everybody. Done, ma.